We're moving on to the panel discussion now. Hello out there. Thank you. If I could get everyone's attention, we are moving on to the panel discussion now. So I'd invite our four panellists to be seated. And I'd also like to welcome back our people online. So we do need to start now because the people online will be expecting that with the timetable and so on. And we'll finish this session at about 7 o'clock or so. So if I could have our four speakers back. Great. So I'll just open the floor for discussion. One thing I did want to say, Paul, you had a very interesting question about cell culture with regard to flu, with cell culture vaccines. I don't know if you want to put it again, but how close can we go? How practical is it for manufacturers would be one of my questions. How practical is it for the regulators? Will there be reagents available and so on? I mean, how close can we go, or how further away can we go from the October ARVC decision? Maybe Ian would like to answer that, but if you'd like to expand on it, Paul, you may have something else.
No, I mean, I think that there are some real opportunities with what's starting to come in the pipeline, and they're very real, that they are going to be here in 12 months. And they're not going to be globally in 12 months, so there's still going to be a WHO Southern Hemisphere decision in September. And so we're going to miss the whole benefit of that and the opportunity to perhaps go back to quadrivalent and put a second H3N2 in. I mean, all of that will be dependent on having good quality information at a later time. It sounds like that's something ACDC can be involved in, but obviously, as Stephanie was saying, they're going to need to be stuff put around that in order to make that happen.
Yeah, there's a lot of players involved. Ian, do you want to make any comment?
Well, I think you have two things in that conversation, Paul. One is cell-cultured vaccine, and I think there is some advantage in cell culture. Sometimes it's a bit overstated by Seqirus, but I think in a normal year, 5 to 20% improvement in vaccine effectiveness is probably could be put down to cell-based vaccines. We don't have enough cell-based vaccines in Australia currently to use that as a primary recommendation. JCVI in the UK did make a recommendation for cell vaccines over egg vaccines a few years ago. I'm not sure whether that's still current. So I think cell-based vaccines, and the other one is the Sanofi Flublok product, which is a recombinant product made in insects, so that's also cell-based, so non-egg. Both of those vaccines should have some improvement over the basic egg vaccines, but some years it won't be that big, so I don't think that's the final solution. And the other one you're talking about there is putting into another component into the vaccine. So instead of having two H3s or two H1s, instead of having one H1, one H3, you can have two of the others. Certainly that's something we're interested in doing. We've done a serological trial with Sanofi. Those data are still under wraps, but take it from me, it looks pretty good. And that paper will come out soon, but that's only serological data. There's no efficacy data there, so whether that will be enough in the new administration, such as what's happening in the FDA, who knows? There's a number of other complications about having two H3s or two H1s in the vaccines in terms of the logistics of doing that, and also the QC on those vaccines. You have to be able to detect each one of those individually in the vaccine. So there are a few tricky things in that if we go down that track. But that's certainly an option and shouldn't be dismissed lightly.
I think Paul's other question, Ian, was whether the timeline between when a decision is made and the strains are selected and then when it first goes into arms the next year, could that timeline be shortened? And then if we had a situation like this year where K appeared late, could that strain be changed at the last minute?
Most of the industry would have a complete fit if you told them you wanted to change any of the timelines. I think in the Southern Hemisphere there is scope to do that, although they'll tell you they can't do it in a pink fit. There probably is a small window there, probably of a month or so you could do that. And that probably could have made a difference. We saw the K variant coming, and we saw it at the September meeting for WHO. We saw it. It was quite evident here in Australia. We saw it was coming. And we picked the next closest thing we had to it. So if we had another month, we might have had some vaccine candidates. The majority of the vaccine is still made the traditional way, so you have to have isolates. So either cell cultured isolates ready to go or egg isolates ready to go when you make that decision. And the egg isolates are not just something you stick in an egg, there's a reassorting process as well. So it all takes time. So I think a month you could probably do. Anything more than that and you might end up with no vaccine.
Okay.
Paul, perhaps for Frank, it's interesting looking at getting ourselves back from 92 to 95 or 96. The paediatric flu vaccine rate is, a fifth of that or a quarter of that or whatever. There have been discussions in the past about changing this from get your kid vaccinated at the start of winter to saying this is now part of the NIP, that depending on the year, either at 6 months or at 12 months, flu vaccine becomes part of the NIP rather than something we deal with separately. I mean, I'm a little bit suspicious based on what Ben Cowling said from Hong Kong that flu mist won't be the panacea that gets us up to a 60% coverage or something because of the parents being unhappy about side effects. So why can't we add flu to the NIP?
Well, flu is on the NIP. Are you asking, should we be adding it to the fully vaccinated?
It'd be actually part of the
coverage
schedule, so that we actually say that, at 6 months, we replace the fact that you don't have to have a drink anymore with the fact that we'll give you your flu vaccine, depending on the time of year. And if the time of year is inappropriate, at 12 months we add the flu vaccine then. Our coverage would increase because the kids come to get their shots. Very rarely do they come to get specific vaccines.
That is, probably a better question for Christine McCartney to answer. Me, as in terms of the schedule. I thought you were putting up your hand then to answer that.
I think LAIV, just to remind everybody, is only registered from 2 years and above. So I think, Paul, but your point is for inactivated influenza vaccine at those routine NIP schedule points. And I think that is promoted, and we have plenty of data on concomitant vaccine to show it's safe, and there's no significant... you have immunogenicity jumping up and down in different studies, but we don't believe that necessarily is an issue. So I think it's more of a systems issue of how, we really genuinely get those offerings of an influenza vaccine to occur. And we've really only got a 6-month schedule point and a 12-month schedule point. We know in pregnant women, the time that people give the vaccine is just before and during the influenza season. Even though we should give it all year round, it's really not thought about outside influenza season, whereas there's value in giving it all year round because the baby's going to be born later into influenza season. So we're not doing a good enough job, I think, in those influenza vaccine promotion efforts year round.
And so the National Vaccination Insights Project has included questions specifically about influenza in the surveys, and so you can look at what parents say about that. And unsurprisingly, we know for decades that there's been general concerns across all ages about influenza vaccine effectiveness, which is unsurprising given it is only moderately effective. So there's a lot of other factors around than just, the schedule. It's about addressing all of those. And LAIV offers another tool potentially to improve coverage. Certainly NC's social science team has done interviews with parents for New South Wales and parents even of children who hadn't been vaccinated for flu in previous years said that they were quite open to the idea of this new non-needle based vaccine. So we're going to be monitoring coverage very closely in the coming year and comparing states with programs and those without, and a greater breakdown of age cohorts to see if there is any impact on coverage.
I think the benefit of LIV is the possibility of a school-based program, and that's not what's going to be proposed even in WA, where they're going to have up to 12 years old. I think the UK get up to about 50-55% coverage, a little bit lower in the secondary schools than the primary schools, but it's just probably not possible to do an injectable vaccine program in schools, but it certainly would be for LAIV.
Question from Tony.
Alan, what do you think your 6-month versus 12-month data, particularly in people over the age of 70, means for once a year bivalent vaccines, flu and COVID, in terms of which is currently being planned by several vaccine companies?
Yeah, it'd be really interesting. I think it's difficult to know. It is a moving target because the hospitalisation rates from COVID are falling, and even from 2 years ago to last year, COVID hospitalisations are well down, and they presumably will continue to go down. So I think it is difficult, and I think that's one for modelling out the benefit of having a combined program and all increased coverage. At the moment, the main issue with COVID vaccines is hardly anyone's getting it. So 40% in maybe over 75s, but hardly anyone other than that.
But Alan, me right here beside you. We're still getting 2 peaks of COVID every year, right? And why is that? And if it's a 6-month vaccine effectiveness and we get 2 peaks, maybe yearly's not going to do it.
Yeah, that's entirely true, but again, it is still falling. And then I think there's also the issue of, do we know exactly when? It does seem to be a summer wave and a winter wave. We haven't really had a summer wave this year, at least so far. So it's really hard to give advice to say 6 months and it should be here and here, when you've got to plan the programs well ahead of time.
The coverage is converging too, with flu dropping from 70 to 61% and 42% for COVID. So the benefits are getting less.
Yeah, the hope is that it would probably boost up the COVID coverage than pull down the flu coverage, but yes.
Rod, and then at the back.
Thanks. My question to Ian. Yeah, you had a throwaway line. I think you were suggesting that maybe the point of care testing for flu might be 10 times the incidence. So is it 10 times as bad? The second part of it was it more infectious and less severe? Was that your impression? And thirdly, the decreased deaths in America in children. Does Kennedy get the credit for that?
I'm sure he'll take it, going backwards. Look, I think, H3 traditionally is more severe in the elderly. In the US last year, they had a mix of H3 and H1, so maybe the worst of both worlds, that accounted for their higher number of paediatric deaths. It wasn't that much more on the previous year, but it was higher. In terms of RATs, or rapid antigen tests, they're not counted in this NNDSS numbers. The only ones out that are counted if they're using a RAT is if it's done in the laboratory. So Joe Blow, you, me, the rest of the group here are not contributing NNDSS numbers. So it's not due to RAT numbers there. So the RATs you can buy now and test at home, that data just gets lost. I've always wanted somebody to do a conversion from NNDS numbers to real numbers. Nobody will give me that number, so I just tell everybody 10 or 20 times, but who really knows what the number is? And what was the middle question? There was 3. Try and limit your questions to 1. I think that's the take-home message. For the K variant, not so much for the H1 pandemic, for the K variant, it was definitely very highly transmissible for some reason, which we don't fully understand, and especially in the younger age groups under 30, but no more severe, I should say. It still ended up with some kiddies in hospital, but very few in ICU from the study we did with New South Wales, with the Children's Hospital at Westmead. So there was no increase evidence over previous H3s that had circulated earlier in the year, which weren't K-clade.
So there's a question, table 12 at the back. Good question.
Hi. I'm just wondering about the funding, because I work in local council and the funding is appalling for on the ground for immunisations. The council has to fund it, basically. And I'm just wondering who is funding immunisations on the ground. And another question, I think if we are looked at that Australian-wide, the most of the areas where there's the numbers have gone low is in the outback Australia, outback West Australia, Pilbara, Northern Territory, Queensland, where all Aboriginal communities are. And what is the funding like there? Because really, if there's going to be an outbreak of measles or rotavirus, which was recently around in the Kimberley region, where babies had to go down to Perth and Darwin, and quite a significant number of babies went to hospital away from their hometown. So, due to lack of immunisations. So, what's happening with the funding on the ground to going into those Aboriginal communities in order, and that, if you're all talking about boosting the numbers, boosting the Aboriginal numbers will boost the national numbers.
I'm happy to answer part of the second question there. So Nigel did show that figure, which is from our report, but I think it is potentially often misinterpreted a bit because we're talking about 2-dose measles, mumps, rubella vaccine coverage at 2 years of age. And so you've got the hotspot areas around the north coast of New South Wales and similar places with high prevalence of vaccine refusers, but the low coverage in remote areas with high Aboriginal populations, that is about timeliness. Aboriginal and Torres Strait Islander kids, there's always been, for a long time, issues with timeliness. It's harder to access vaccination services in remote areas, but if you follow them through, it's like those figures I was giving of coverage at 60 months of age. Across the board, they're much higher, and in Aboriginal kids, coverage at 60 months of age for measles, mumps, rubella and most vaccines is actually higher than the overall population. So, yeah, so funding, I'm not an expert in that area, but it's obviously a combination of the Commonwealth and states and territories fund immunisation in general. As David said, there's $30 million has been given to NACCHO and the community-controlled sector to try and boost uptake. So obviously we need more, and it needs to be more sustainable. But the actual details, somebody else.
I wonder if Anna Pete might want to comment on that. I understand there's funding, various different pots of funding, but.
Yeah, look, our federation has created quite a complex funding situation, but we do effectively fund the purchase of the vaccines at the Commonwealth level. We then also support the states and territories, do vaccine rollouts and whatnot. And we do know in particular that First Nations people right across the country do have difficulties getting access to vaccines. So we have supported the First Nations Vaccine Support Program, which provides grants awarded through NACCHO to local communities to try and boost their uptake rates. We had a very similar model for COVID-19, and we did see in First Nations communities support for immunisation coordinators and whatnot did lift vaccination rates in some communities, not all, and what we're trying to do is roll that out more broadly for all vaccines across all age groups. I guess in terms of how states and territories fund local councils, that clearly varies across all of the different states and territories. But I guess with it, we probably have to speak about, what community that you're specifically talking about to be able to, I guess, answer your question specifically. But it's quite complex.
And if I could just add, I chose 2-year-old data just to be consistent throughout the talk. And, obviously some of the 5-year-old data coverage looks looks better. And just in terms of that coverage, I agree with you completely around some of those areas in the outback and Northern Territory. But you know, the Gold Coast hinterland, in the Noosa hinterland, you know, there's a mixture of alternative lifestylers and very wealthy people. And there are certain suburbs in Sydney where vaccination rates aren't actually that great. You know, I don't know, I'd call them the rich misinformed, perhaps, in a way. It's, you know, and whether, and people, someone may know the answer much better than I. This is not what I do. I'm a virologist after all. But, you know, is it the alternative lifestylers or the rich misinformed in Noosa that are doing this, or in the northern, you know, in the northern New South Wales areas, clearly places like Nimbin, Byron Bay are clearly have a higher concentration of old people who have an alternative lifestyle, I guess, in some ways. But they're also the Chris Hemsworths of this world that live in those areas, right? So it's an interesting observation in itself as to whether it's not just poorly resourced areas. Perhaps these areas are quite well resourced, but I guess have communities where vaccination is not an important thing for them, would be maybe the best way to put it, or they're misinformed about it.
Okay, our final two questions. Paul first,
Well,
and then
I was
Alan.
going to make a comment rather than a question. We have to make a decision soon about whether or not we believe councils play an important part. They vary from state to state. They were at one point almost 50% of Victorian vaccine delivery. The models have been such that continue to discourage councils. You know, we were funding them on the basis of so much per antigen, and then over a period of time we went from 3 HPVs to 1, so we took, you know, 2/3 of their coverage from that. In Victoria, they've given them a new database to use, and they charge them to use the database. You know, so there are all those sorts of things that say to councils, we're not really sure that you make a contribution. But if you look at the things that did work in COVID, you know, vaccine champions going and talking to religious groups and doing things specifically at a local level, these council clinics are right in the middle of communities, and they actually provide access to different groups, and they provide access to vaccines for homeless people and so on. So I think it's disappointing that increasingly we make it economically unviable for them to actually run. I mean, in Victoria, the MUV, the Municipal Association, made a decision that it was too dangerous for councils to give COVID vaccines. So while we were giving, you know, Moderna through pharmacies and all of the rest of it, if you went to a council clinic, you couldn't give a COVID vaccine because they'd said it was too risky, you know. And so there's a lot of that just needs somebody to take a look at it and say, we're going to fix this.
Final word, Alan.
Thanks, Gary. I'm going to sneak in two questions, Gary, because I've been very quiet up until now. First is for Frank. The previous couple of discussions were around the areas where low vaccination is and how you might encourage improved vaccination in those areas. But though a lot of those low vaccination areas that have been discussed were very small groups, very small communities, and clearly not a big influence on the overall picture. And you have done, or you referred to surveys in 2,000 people, but I'm just wondering whether those were strictly random online surveys, or whether there was any attempt to actually focus in those areas where there is a disproportionately low vaccination rate.
Those National Vaccination Insight surveys are nationally representative, so you couldn't call them random surveys, and so they're nationally representative. They're not intended to oversample in certain areas, but certainly we do have, you know, lots of plans given suitable funding to expand some of those surveys across age groups and geographic areas over time. But as you say, yeah, so a lot of those vaccine refuser communities like North Coast New South Wales and Sunshine Coast hinterland, they are quite small areas. And while, you know, there obviously is theoretically a high risk of communicable diseases, and so the biggest measles outbreak we had in the last 10 years, 15 years was in 2012, I think it was, or which was in southwestern Sydney, in area with generally quite high coverage, but lower coverage in particular population groups. I think that was Pacific communities there. So obviously you can focus on national coverage. If you get back to 95% national coverage, it's not necessarily going to stop outbreaks. If you get back to 100% coverage, yeah, that might. But obviously there's lots of geographic and other demographic groups. So, I mean, we just have to, do our best to turn around the trend, because it's obviously going the wrong direction, and also identify other groups, like you say, so further work to identify areas where targeted campaigns and interventions could be useful.
Thank you. And the second question is directed to Ian.
Lucky me.
The vaccination effectiveness against that K strain was, within living memory, remarkably high compared with other H3 strains, and yet this is a strain which has drifted a long way. Did that surprise you? That's an easy answer. And
Very
secondly,
much so.
do you have an explanation?
Well, look, I think, I think it's high and unexpectedly high. I think, if you read Danuta's paper, she thinks she's got an explanation where you have, some of these similar changes that have occurred with this K variant occurring in previous years. And you have to be over 30 years of age, so you qualify there, Alan, that might have some protective effect against this K. It was quite surprising, because we were expecting it would be a shocker by the time it got to the Northern Hemisphere, that's for sure. There is recent data coming out of the UK which shows that their VEs have waned. So that data will be published shortly, I'm sure. So I think, the good news has already been here, and it will probably not be as good by the time the season's finished in the UK. Although again, it came at the end of our vaccination, end of our season, so the vaccination was already 6 months plus. So if anything was going to be bad, our data should have been even worse. So watch this space, Alan. We're working on it. Maybe you can give me your own explanation over drinks.